Good evening, and thank you, Ms. Christina, for the kind introduction, and thank you for those who are joining us this evening. I'll go over the recently published recommendations on the use for multimodality cardiovascular imaging of patients with hypertrophic cardiomyopathy. It was recently published in the Journal of the American Society of Echo, and this is a combined effort led by the American Society of Echocardiography in collaboration with the American Society of Nuclear Cardiology, the Society for Cardiovascular Magnetic Resonance, and the Society of Cardiovascular Computed Tomography. My colleagues and I worked on this document, and it is my distinct pleasure and honor to present on their behalf today this webinar. I don't have any disclosures relevant to the webinar. We all recognize the phenotypes of hypertrophic cardiomyopathy by histopathology, so to speak. Part of it is hypertrophy that you can see on a gross anatomic specimen, as you notice here, in addition to myocyte hypertrophy with disarray, as you see in the middle panel, and fibrosis. The fibrosis can be both interstitial fibrosis as well as replacement fibrosis for the lost myocytes. I will submit to you that we are now able to look solidly at the two components of hypertrophy and disarray by imaging, and there have been significant strides as well to recognize the presence of disarray, albeit in the research, not the ready to practice clinical arena as far as disarray is concerned. The outline of the document and the webinar include a discussion of how to evaluate patients with increased wall thickness, a look at myocardial function, dynamic obstruction and mitral valve disease, imaging for risk stratification of sudden cardiac death, ischemia evaluation, role of imaging in selection of treatment, guiding treatment, and assessing the response, the cardiac response to the treatment of dynamic obstruction, as well as screening. Let's start by morphology. And we'll start by the first tool that is frequently obtained is echocardiography. Many patients may be diagnosed for the first time after an echocardiogram is performed, say for the reason of shortness of breath. It is important when we look at measurements of wall thickness to combine the parasternal and the short axis views together and to avoid off-axis cuts. Off-axis cuts will result in increased thickness, and obviously as a result of that, errors, not just in segmental thickness, but also in ventricular mass calculations if one were to use some of the uniform equations, as opposed to 3D, which is the recommended method for looking at LV mass by echo. The slide shows you, and it's an image from the document that was published, in the red line, the proper septal thickness, and in the blue line, an erroneous measurement where the right ventricular side of the septum is also measured. Let's look at some examples. That's a case of massive asymmetric hypertrophy, a case of concentric hypertrophy where you see uniform increase in wall thickness all around the myocardium. Apical hypertrophy is one of the more challenging morphologies to identify, and it is possible if you have a patient where there is not a challenge in, or you're not concerned about too much attenuation, is the use of high-frequency transducers. You can see here very good resolution and identification of significant degree of apical hypertrophy. More frequently, one needs to use the ultrasound enhancing agents. And if you have a case referred with the possibility of hypertrophic cardiomyopathy or EKG findings that raise the possibility of apical hypertrophy, one should have a real low threshold for using ultrasound enhancing agents. They do not only recognize the presence of hypertrophy, but they can also identify the presence of an apical aneurysm, or thrombi present in the apex, these have a profound impact on how a patient will be managed down the line. These are the different morphologies you can see. You see in panel A, the sigmoid septum with systolic anterior motion of the mitral valve, reversed curvature in B, apical hypertrophy in C, mid-ventricular obstruction with an apical aneurysm in D, and severe concentric hypertrophy in panel E. The issue with oblique cuts and the erroneous measurements coming as a result of these oblique measurements do not apply only for echo, but also for CMR. And you see here again a nice example where the oblique cut results in an erroneous measurement for the septal thickness of 23 millimeters when it is only 18 millimeters. In general, we start by echocardiography as the first imaging modality. Sometimes we see an abnormal EKG and an echo that appears normal, or you are looking at septal thickness that are of borderline question. For example, something that is maybe 14 millimeters or 12 millimeters in somebody with a positive family history. In these cases, one should have a lower threshold to proceed to CMR, which has solid spatial resolution. You can look at short axis cuts in several stacks and use these to obtain left ventricular mass and characterize which thickness are present. One of the walls that is frequently not easily recognized by echo is anterolateral wall thickness. This is easier to identify by CMR. You can also see apical hypertrophy by CMR, as you see in this example. CMR can also show the presence of crypts, as you notice here in the inferior lateral wall. They can also be seen in the inferior septum. Crypts can be seen in patients with who carry a positive genotype, a pathogenic mutation for hypertrophic cardiomyopathy, but who do not yet have hypertrophy. They can be seen in patients with actual hypertrophic cardiomyopathy and pathologic hypertrophy, but they have also been reported in normals. Sometimes we have patients who cannot go through CMR. For example, they have an ICD lead from an older generation. Nowadays, we do not really encounter much of that concern. Or somebody who's claustrophobic and cannot go through the CMR despite the use of minor tranquilizers. CT, cardiac CT can come in handy in these cases, and you see a nice case here with severe asymmetric septal hypertrophy. You can do segmental wall thickness similar to CMR, and you can see here a nice example of apical hypertrophy by cardiac CT. It is important to alert the labs whenever you're referring a case that you're concerned about the possibility of hypertrophic cardiomyopathy. Aside from morphology, imaging can give you insights into systolic function. There are many tools to assess systolic function day-to-day practice and in the research arena. I will focus on the clinical tools, and these include ejection fraction, usually biplane ejection fraction or 3D ventricular volumes and ejection fraction obtained this way, and global longitudinal strain. All other techniques have been used and looked at in hypertrophic cardiomyopathy, but the most extensive clinical data are there for ejection fraction and strain. Is it important to know what the ejection fraction is? Absolutely, and you want to be accurate with that, which means if you don't see volumes well, give ultrasound enhancing agents and use these to get left ventricular ejection fraction. Here you see the outcome in two groups of patients, a group with classic hypertrophic cardiomyopathy where the walls are thick, ventricular ejection fraction is preserved, versus a group that has entered into a dilated hypokinetic phase of hypertrophic cardiomyopathy, something that maybe 4 to 8% of cases can get into. Once the ventricle enters into this stage, they are treated differently, the way you would treat patients with reduced ejection fraction that has implications for risk stratification and ICD implantation. So this is a major impact on patient management. And certainly now with the use of myosin inhibitors, you want to be accurate and careful with tracking the ejection fraction. I'll skip myocardial velocities and we'll take a quick look at global strain from a normal subject and from a patient with hypertrophic cardiomyopathy. Notice how profoundly this reduced in that apical four-chamber view at only 7%. Nowadays, the ultrasound systems can provide you with segmental strain values as well as with the polar maps. With respect to the two examples you see here, you see a case of asymmetric hypertrophy, and you see segmental strain predominantly reduced in these basal segments of the anterior and inferior septum, to some extent part of the mid-inferior septum. And that's a case of apical hypertrophic cardiomyopathy, and you see that the reduced strain noted in the apical region for that heart. There are growing data linking the presence of reduced global longitudinal strain with adverse outcomes, and some of these adverse outcomes were non-sustained ventricular tachycardia in one study, but also heart failure and death in other studies. Let's talk about diastolic function. Diastolic function is a very dysfunction, I should say, is a very common problem in patients with hypertrophic cardiomyopathy, important contributor to their symptoms, and to recognize it, and if needed, now there are tools that can help improve it. So starting first with the ventricular pressure recording, you see here a patient who went to the cath lab with severe symptoms. The minimum pressure, which should normally be close to zero, is markedly elevated, about 17 millimeters mercury. The pre-A pressure before the atrium contracts, that is pressure very similar to the left atrial pressure, it's about 24 millimeters mercury, and an end diastolic pressure that is well in the 30s. Notice the marked increase in pressure after atrial contraction due to the increased late diastolic stiffness of that ventricle. The available tools we have include mitral inflow and annular velocities. These are frequently reduced in many patients with hypertrophic cardiomyopathy, but can be preserved in younger individuals with lesser degrees of hypertrophy. Remember that increased late diastolic pressure and the 30 millimeters mercury end diastolic pressure in that previous pressure recording. These can be detected if you have a good sampling of the pulmonary veins, as you see in this case with the guidance of color Doppler. And you see this forward flow into the atrium from the vein during systole, diastole, as well as the backward flow with atrial contraction. Comparing the duration of that atrial velocity in the pulmonary vein with forward flow across the mitral valve, you can see that the ejection from the atrium into the vein is a much longer duration than that into the ventricle. That's a good indicator of increased left ventricular and diastolic pressure, which many patients have. Another interesting observation with the increased end diastolic pressure, the actual flow from the atrium into the ventricle because of atrial contraction tends to be reduced and abbreviated. So the A duration is short, but also if you look at the absolute velocity tends to be on the lower side. It decelerates fast. And in this case, you can see that it even ends before the QRS complex. If you look at patients who are compensated or relatively compensated, so to speak, many times they have the increased end diastolic pressure with that prominent atrial velocity in the veins, as you see in this example. But if you look at the mitral inflow and you combine it with the annular early diastolic velocity taken here from the lateral side, and you can appreciate that it is indeed preserved. It's more than 10 centimeters per second. This ratio is normal. And so there will be patients who will have increased end diastolic pressure, normal mean left atrial pressure, typically at rest. If their disease progresses, then you will see an increase in the E to E prime ratio, along with increase in the PA systolic pressure, as you see in this case, where the peak tricuspid regurg velocity is about 3 meters per second, corresponding to right ventricular right atrial pressure gradient of 36 millimeters mercury. With further progression of diastolic dysfunction, restrictive filling is seen, and restrictive filling is not just defined by the E to A ratio, it's also these very small annular velocities. In here, it's about 2.5 centimeters per second at the septum, and slightly more than 3.5 on the lateral side. So the E to E prime ratios are markedly increased. This finding is associated with a high incidence of heart failure symptoms and hospitalizations because of heart failure, and can be seen in this group of patients with normal ejection fraction. More recently, atrial strain has been looked at, and I'm picking this particular study as a quick example, showing you that when the exercise tolerance, one of the exercise tolerance metrics, peak myocardial oxygen consumption, is reduced, the reservoir function of the left atrium is reduced, as is the conduit function, though there was not an apparent difference in the atrial pump function. So the guidelines advocate that if you have a decent signal with atrial strain and your lab has been doing it for some time, and you are doing it with the same ultrasound system, it is very reasonable to report atrial reservoir strain along with the other findings in the echo report. The guidelines also include an algorithm for the estimation of left atrial pressure based on the maximum left atrial volume index, average E to E prime ratio, and peak tricuspid regurgitation velocity. Many times, the peak TR is not that clear. One has to aim for it, look for it in multiple windows. If saline intravenous injection will be used, make use of that. If ultrasound enhancing agents are going to be given for better endocardial border visualization, you want to make use of that so you get a complete TR jet and you do not miss on one of these three signals. Can you look at other variables in case you are in that middle box where one variable is only available, or two variables, and they are sort of contradictory to one another? Yes, a left atrial reservoir strain less than 18% would tip the balance towards the conclusion that left atrial pressure is elevated, albeit more data are needed, particularly in patients with hypertrophic cardiomyopathy. What is the substrate for the abnormal diastolic function in hypertrophic cardiomyopathy? Part of it is the myocyte problems and the prolonged strong interactions between actin and myosin cross bridges formation, but also there are structural changes with replacement fibrosis, as you see in this slide, taken from a patient with hypertrophic cardiomyopathy and good degree with late gadolinium enhancement seen in the septum. Look at the mitral inflow with a peak E of almost 1 meter per second and very small annular velocities both at the septal and lateral sides. So when you get the CMR report, look for the fibrosis burden as well as the distribution of the fibrosis. Not simply for diastolic function, and I say simply not to minimize the importance of diastolic function, but you will see that that also plays an important role for risk stratification. Another interesting observation in patients with cardiovascular disease is the changes that happen in the interstitium with expanded extracellular volume space, taken here from a patient with hypertrophic cardiomyopathy compared to the normal subject. That increased extracellular volume can correspond to the presence of increased interstitial fibrosis and is associated with reduced exercise tolerance. These are not routinely reported in all CMR labs, but nevertheless, they are playing a greater importance, not just for hypertrophic cardiomyopathy, I would say, but in general for many cardiovascular diseases. Let's go to dynamic obstruction. And dynamic obstruction is not uncommon. If you look carefully for it, be it at rest or with provocation, you may find it in 2/3 of the cases or slightly more than that. That's an example taken from the cath lab with a pressure in the ventricle shown in blue and in the aorta shown in red with the gradient. We do very well by Doppler echocardiography in diagnosing dynamic obstruction. These are some of the mechanisms that play a role in development of dynamic obstruction. One is the anterior displacement of the papillary muscles, as you see here. It brings the mitral valve apparatus closer to the septum. Frequently, there is mitral leaflet elongation relative to the long axis of that ventricle. Because the posterior leaflet has reduced mobility compared to the anterior leaflet, it does not meet the anterior leaflet all the way, and you have a segment of that anterior leaflet that becomes amenable to the drag forces that result in pushing it towards the interventricular septum and producing obstruction. Certainly, the curvature of the septum and the thickness of the septum will also bring it closer to that mitral valve. And in many situations, the hyperdynamic basal septum as well will bring the anterior leaflet and the septum closer to one another during systole. In many patients, the degree of systolic anterior motion does not relate to the severity of hypertrophy, and mitral valve abnormalities can play a dominant role in some cases. This is important because that has implications for treatment, and we'll try to touch on that in the later part of the webinar. Papillary muscle abnormalities are very common in hypertrophic cardiomyopathy patients. We talked about the anterior displacement, and that's from an actual patient showing you how the papillary muscle is displaced anteriorly. And in some cases, the papillary muscle is bifid, as you see here. I will also tell you that if you look at the outflow tract, in many cases, there are frequently abnormal muscle bundles that can contribute to the presence of dynamic obstruction. These may be more easily recognized by CMR than by echocardiography. This is a case where there is anomalous insertion of the papillary muscle. You see the papillary muscle almost inserting directly into the anterior mitral leaflet without chordal apparatus. Sometimes it's recognizable with the standard views. In many cases, it needs off-axis views. Again, CMR can be helpful in these cases. Example of an apically displaced papillary muscle contributing to left ventricular outflow tract obstruction is shown here with CMR. And that's the classic finding with the M mode showing the contact between the anterior leaflet of the mitral valve and the septum. There it is by 2D. There is the color Doppler with acceleration into the outflow tract, as well as the posterior and lateral directed jet of mitral regurgitation. That's the classic finding that if you're able to see, doesn't really pose a challenge for diagnosis. You can look at this dynamic obstruction with color Doppler, makes it easier to recognize it sometimes if you have challenging 2D images, and you can see it in the paralong views in the apical 5-chamber view, as well as the apical long axis view, as you see here. We do, if you were to call this, mapping using pulse wave Doppler, because you see aliasing when the sample volume is present at the level of obstruction. So that identifies where it is. Continuous wave Doppler will not allow you to identify where the obstruction is present, but will make it possible what is the peak obstruction. That's the drop in velocities that can be seen with the as a result of the obstruction happening and the increased afterload for the ventricle. That was termed by Dr. Sherif the lobster claw abnormality. If you look for it carefully in patients with obstruction, it is not an infrequent finding. I want to show you different morphologies. The guidelines document drew attention to these. Sometimes you have the dagger-shaped later peaking velocity. as you see in this example. Sometimes it is more of a symmetric velocity, the signal for dynamic obstruction. You may see this, you may see that as well. Do you need transesophageal echocardiography? Not really, to look for dynamic obstruction. This is more applicable in the OR setting, or if you are doing a case where you're going for percutaneous plication of the mitral valve, catheter edge-to-edge repair. In patients who do not have much of an increased wall thickness, again, you see the acceleration into the outflow tract and the mitral regurgitation jet in 5-chamber and lung access piece. 3D is very useful as well, and that's a nice case showing you the apposition of the anterior leaflet with the septum. And again, if your lab is doing it routinely, you will gain more confidence and you'll be more comfortable with these acquisitions. And obviously the physicians will appreciate it a lot. As you can see, when the images are so clear, there are really no challenges in identification of pathology. That's a case of a late peaking left ventricular outflow tract obstruction velocity. It's about between maybe 4.5 and 5 meters per second, closer to 5 meters per second or so. This is a case of the same patient, but with the mitral regurgitation jet. You can appreciate that the mitral regurg jet here is exceeding 7 meters per second. And you can see there is the dynamic obstruction jet, and there is the MR jet. When they are sort of close to one another, despite your better efforts, it may be hard to distinguish them. And it may need a sweep where you aim on purpose for the MR and then you try to move away from that location and capture the flow through the outflow tract and the obstruction there. Sometimes we see pretty high velocities and the question comes, does this patient really have a significant degree of obstruction, as that peak velocity tells us, or not? Here, the MR jet could be very helpful. I'll show you through this example how that works. So we align with the mitral regurgitation on purpose, and we are now knowing that the peak MR velocity is 7.5 meters per second. We measure systolic blood pressure, and we make the assumption that the pressure you get over the brachial artery is the same as in the central aorta. It's a big assumption, but a practical one that will be useful for us. We can say the left atrial pressure is about 20. As you will see, it is not going to make a major impact. But it is important to recognize that we need some estimation of left atrial pressure. So now if we go to the MR jet, we say the difference between the peak systolic pressure in the ventricle and the left atrial pressure is given by 4V squared. So we know now that this is 225 millimeters mercury. If we look at the LV systolic pressure, as the difference between the left ventricular and the left atrial pressure, then adding the left atrial pressure to the 225 here, then you end up with a systolic pressure of 245. Now we turn our attention to the left ventricular outflow tract gradient, and this is the difference between systolic pressure in the ventricle and systolic blood pressure. Knowing the systolic pressure at 170, we can estimate a gradient of about 75 millimeters mercury, or a velocity between 4 and 5 meters per second. So then I am more comfortable that, yes, this is indeed the true velocity. If you ignore the left atrial pressure, then you will end up with some underestimation of the gradient through the outflow tract. There are other causes of obstruction, aortic stenosis. Sometimes they coexist. Sometimes patients with aortic stenosis have dynamic obstruction, not because of HCM. And sometimes both diseases coexist. Here, planimetry of the aortic valve is very useful. We think of TEE, but certainly nowadays you have cardiac CT and you have CMR that can help. There is a big difference between the outflow tract velocity signal and the aortic stenosis signal. Notice the later peaking as opposed to the early peaking here. This is the superimposed two signals. The brighter one with the red arrow is the outflow tract signal, and the later peaking velocity, shown here by that white arrow, but also shown on that third beat, is between 3 and 4 meters per second is the aortic stenosis jet. Patients sometimes have a fixed obstruction, subaortic, because of the presence of a subaortic membrane. These may be seen sometimes with transthoracic, sometimes you need transesophageal echo to visualize them, or CMR to visualize them. Here it is nicely seen. And usually their signals are earlier peaking signals, not the later peaking signals, the dagger-shaped signals that you see with dynamic obstruction. Also, aortic regurgitation is not uncommon in the presence of a subaortic membrane, or other reasons for subaortic pathological narrowing, whereas they are much less common with hypertrophic cardiomyopathy. Color Doppler is very helpful in showing you where the obstruction is present, and this is a case where you see obstruction happening more in the mid to distal cavity of the ventricle, identified nicely by Color Doppler and then CW. So if we have a patient who's symptomatic at rest, but you don't have a significant degree of obstruction, it is it is standard of care to proceed to look for provocable gradients. There are several tools for the echo lab. The ones that we use are exercise. Very few labs use amyl nitrite, Valsalva. Squat to stand, particularly several times in the echo lab. If you have a patient who cannot do any of the above, maybe low dose dobutamine can be considered. Isoproterenol is used in the cath lab, as does PVC induction in the cath lab. Other situations that can make dynamic obstruction more likely in the absence of hypertrophic cardiomyopathy, one should be aware of these as the setting of a hyperdynamic state with anemia, hypovolemia, small ventricles that are hyperdynamic, and sometimes after mitral valve repair. That's the post-PVC, marked drop in the pulse pressure and a marked increase in the pressure gradient between the ventricle and the aorta. For us in the echo lab, as just mentioned, our routine is the Valsalva first, and if a patient cannot do the Valsalva effectively, then several attempts with squat to standing. This is an algorithm that is also in the guidelines. If you have a symptomatic patient, you want to recognize the presence of obstruction, because now obstruction becomes a target for treatment. And these are the tools we mentioned. The 50 millimeters cutoff is the cutoff at which you start entertaining other options for treatment. So if this gradient at rest or with provocation is less than 50, the next step is exercise stress echo, preferably upright exercise with a treadmill or an upright bike if you have one, but may consider a supine bike if the patient cannot do it, though it is easier to induce more significant gradients with upright exercise as opposed to supine exercise. If the gradient is 50 or above, then they have obstructive hypertrophic cardiomyopathy. And if the patient has failed medical therapy, then you can entertain septal reduction therapy with them, assuming that they meet other criteria. If it is less, then you can consider repeating the exam in 1 to 2 years, or if the clinical status changes. Mitral regurgent hypertrophic cardiomyopathy is frequently related to obstruction in many patients. The usual is a posterolateral jet, but sometimes you can see a central or anteromedial jet, even if the etiology is obstruction. However, other reasons that can lead to mitral regurgitation should not be overlooked and can be recognized with imaging, as prolapse, flail, mitral valve segments, or because of infected endocarditis. Clearly, one needs to know the mitral regurgitation mechanism before embarking on non-medical treatment. If it's a primary mitral valve pathology, as say a flail segment, that's a very different treatment than, say, referring a patient for a myectomy and expecting the myectomy by itself to treat it, to treat the mitral regurg, that is. So it is important to have a lower threshold if you do not feel comfortable about what is happening with the mitral valve. to consider transesophageal echo or CMR. That's an example from a patient who was referred with dynamic obstruction, and we noticed anteromedial jet on transthoracic echo and a valve that was not well visualized. You see the flail segment here by TEE and a large anteromedial jet of mitral regurgitation. Midventricular obstruction and apical aneurysms are gaining more and more recognition in the recent HCM registry. It was noted in 3% of the cases. Mid-cavity obliteration may be considered with a gradient of at least 30 millimeters mercury. Sometimes there is complete apposition of the two walls and no actual flow. In this case, the echo will tell you that there is zero gradient really because there is zero flow, but that doesn't mean that there is severe obstruction. So you have to combine the imaging 2D, 3D by echo and CMR along with the Doppler data, not just the Doppler data by itself. The presence of apical aneurysms portends a higher risk for mortality and ventricular arrhythmia, and hence the importance of recognizing them. Here you see the presence of the obstruction, the acceleration of flow by color Doppler, and you see an apical clot. This is a CMR showing you the presence of an apical aneurysm with a clot. The patient placed on anticoagulants and imaged years later showing the resolution of that clot, though of course you still appreciate the aneurysm and you can appreciate that the pap muscles are coming with the walls. Imaging plays an important role in risk stratification. These are the important findings we want to recognize. Maximum wall thickness, this means maximum wall thickness in any segment, not just the septum. And considering the variability of the measurement, you may entertain a cutoff of also 28 millimeters mercury. I would tell you this was obtained by echocardiography, not by CMR. So whether a lower threshold by CMR portends the same outcome as a 30 millimeters mercury by echo remains to be known. Apical aneurysms with a high event rate, late gadolinium enhancement that exceeds 15% of the ventricular mass. An increased size for the left atrium was associated with worse outcome in one study and is included in the hypertrophic cardiomyopathy risk sudden cardiac death calculator. Dynamic obstruction at rest or Valsalva also in that calculator. A reduced ejection fraction, the presence of ischemia, blood flow reserve, and stress myocardial perfusion abnormalities have been associated with higher risk of sudden cardiac death as well. The risk with increased wall thickness is a gradual risk, and so you can see many patients who have encountered the problem of sudden cardiac death and successfully survived it, but do not have these very large maximum wall thickness measurements. The risk with respect to late gadolinium enhancement has been seen in several studies, being associated with higher risk of sudden death as well as total mortality and end-stage hypertrophic cardiomyopathy, the stage where the ventricle is now on the dilated hypokinetic size. That's an example from a patient with apical hypertrophy, and you can see that the aneurysm is replaced with dead scar tissue by CMR. In this case, ischemia CAD evaluation can be done by several tests. I will tell you quickly that ischemia can be due to problems in the major arteries, epicardial arteries, but also there are problems with the microcirculation. This is a nice study by PET showing you the presence of a defect in the lateral wall here that fills nicely on short axis view, as well as seen here in the vertical long axis view. It includes as well the apex that fills nicely, horizontal views showing both the septum filling up some, but particularly the apex and the lateral wall from stress to rest. You can get coronary flow reserve and quantify it by PET, and so compared to SPECT, that would be the preferable tool with functional testing and looking at flow reserve. Cardiac computed tomographic angiography in HCM is another important imaging modality. You see here the septal perforated artery going through the muscle. You can see here a bridge compressing part of that vessel, nicely shown here. And bridges are not uncommon in patients with hypertrophic cardiomyopathy, and it is debatable whether they are associated with higher risk of adverse events or not. Many times patients with hypertrophic cardiomyopathy present with chest pain, and so the approach here is similar to how you approach patients with chest pain in general, with some adaptations, knowing that we are dealing with hypertrophic cardiomyopathy. With a low risk and a pain that is clearly non-cardiac, no further testing really is needed. If it is persistent or there is a high suspicion for CAD, you can consider a calcium score. If it comes back 0, that's where things end. If you are looking at a patient with a low to intermediate risk and they are suitable candidates for CTA, you can proceed to that, and then based on the findings of the CTA, you may or you may not need to go to coronary angiography. Sometimes you have a patient who is not a good candidate for CTA. For example, a patient with arrhythmias has end-stage renal disease or has known CAD, as well as those with a higher risk, more than 50%. In these cases, functional testing is a reasonable approach, preferable PET or CMR versus SPECT or echocardiography in that setting, assuming no contraindications to the CMR. And depending on the findings, again, either medical treatment or, if needed, coronary angiography, going after large epicardial vessels. Sometimes patients are referred for CMR and they come back as part of the CMR report commenting on perfusion abnormalities being present. And then as a clinician, you ask, what should I do next? Here you look at the clinical status, the pretest probability of disease, the size of the defect, and the ejection fraction. If it's a low risk, no further testing. If you want to push it, maybe a calcium scan. If it's a high risk, it is not unreasonable to proceed to angiography, intermediate risk, coronary CT angiography. Echo can guide dynamic obstruction. First, there is medical therapy. Interval imaging at 1 to 2 years is reasonable, or sooner if there are symptomatic changes, because sometimes you can see patients who do not have obstruction may manifest it later on, and sometimes you see the unfortunate group of patients where ventricular systolic function starts to drop. What is the main objective of imaging for patients on medical therapy? You want to look at ventricular size and function, and you want to look for dynamic obstruction. For ejection fraction, you want to see if the ventricle has entered the dilated hypokinetic stage, in which case they receive guideline-directed medical therapy. More recently, myosin inhibitors have become available, and here the main goals are really what happens to the gradient on treatment, as well as quantitative ejection fraction, so as to avoid heart failure due to reduced ejection fraction. Echo plays a critical role during myectomy. You can look at septal thickness, you can look at mitral valve motion, you can look at gradients and what happens to them after surgery. That's a nice example. I would tell you that septal thickness measurements in the immediate post-op setting perhaps can overestimate in some cases the actual thickness, residual thickness that the patient ends up with because of edema of that vessel. You can also use color Doppler, and you should, I wouldn't say can, you should use color Doppler to look for problems. For example, the presence of a VSD. If you start with a septum that is not particularly thick, look for what happens in terms of mitral regurg, look at aortic regurg. Sometimes a coronary cameral fistula can develop, and you can recognize it as well with careful imaging. Alcohol septal ablation is a viable option for patients with dynamic obstruction, and echo plays a critical role in guiding the treatment. When the inflated balloon sits in the target septal perforator artery and before ethanol is injected, the ultrasound enhancing agents can be administered down that lumen of the inflated balloon, or sometimes agitated contrast that the interventional cardiologist is using to visualize the coronaries can be used. What do you want to see when you administer these agents? You want to see where the brightness is and whether it is present at the site where the SAM is taking place and the acceleration of flow is happening, as in this example. We rarely use transesophageal echo, but sometimes it is needed in patients who do not have good windows. And you see here two nice examples, some brightness on the left ventricular side of the septum. Here you see brightness on the right ventricular side. Many times, if the brightness is simply on the right ventricular side of the septum, this would not be a good vessel to target, because you may not result in reduction of the thickness on the side that faces the mitral valve, and you want to alert the interventional cardiologist to seek another septal perforator artery. Of axis views in this case with a patient who was given an ultrasound enhancing agent shows opacification of the papillary muscle. Obviously, you do not want to induce papillary muscle infarction, and you can ask them to avoid injection into the vessel. Alcohol ablation can be very effective in symptomatic treatment. This is a vessel that is occluded after ethanol is injected in it, and you see the gradient pretty high at 115 millimeters mercury before the alcohol ablation. After the alcohol ablation, you see early peaking, not late peaking, indicating abolition of obstruction. Look at the mitral inflow, which was pseudo-normal, and now marked reduction in mitral E velocity, corroborated with a decrease in the peak tricuspid regurg velocity, corresponding to a decrease in RV-RA pressure gradient from 49 millimeters mercury to only 21 millimeters mercury. Transcatheter edge-to-edge repair is considered for patients who have dynamic obstruction, but where the septal thickness is not particularly thick, for example, borderline 15 millimeters mercury. You see here the dynamic obstruction, the MR, some degree of aortic regurg by transesophageal echo. And as the clip is placed, you see the two orifices successfully implemented. The gradient is abolished from a very high value here, approaching 5 meters per second, to no obstruction whatsoever. So in conclusion, imaging is essential for the evaluation of patients with known or suspected hypertrophic cardiomyopathy. To arrive at a diagnosis, it is seldom imaging alone. This should be in conjunction with clinical findings. Imaging plays a critical role in informing risk stratification for sudden cardiac death, as well as the evaluation of patients with chest pain and possible coronary artery disease. Imaging can guide treatment with negative inotropic drugs, septal reduction therapy, and transcatheter edge-to-edge repair of the mitral valve. I would also mention that the most important part is the staff should have a clear understanding of the strengths and limitations of the different imaging modalities and the clinical implications of the findings ascertained by imaging. The results should be communicated clearly to the physicians and the healthcare team taking care of this patient. Thank you. We'll now look for questions. I see 3 questions. How do you perform one of them, squat to stand, while doing transthoracic? So the patient will do the squat to stand several times, and after they have done it several times, you will go for the image acquisition, as opposed during when they are doing that. When they are squatting, the afterload is increased, but when they stand, that changes and the venous return drops, and so the setting is there for dynamic obstruction to be seen. I see a question also related to provocable gradients, is asking how to interpret dobutamine stress in hypertrophic cardiomyopathy. So here the dobutamine stress is only used if the patient is not able to exercise. If the patient is not able to exercise, we would use low-dose dobutamine, not to exceed 20 mics, and you're looking for obstruction that is caused by systolic anterior motion of the mitral valve. You are not looking for intracavitary gradients. I see a question about drag forces and Venturi forces. So the drag forces are the forces which develop when the anterior leaflet or segment of the anterior leaflet is not covered by the posterior leaflet. And these drag forces push the mitral valve towards the septum to produce obstruction. They develop before the obstruction takes place, before you see the increase in the velocities in the outflow tract. The Venturi forces come into play at a later stage, whereby the obstruction now has developed, and you see the kinetic energy resulting in higher pressure gradients. Can you comment on left ventricular outflow tract obstruction without septal hypertrophy or without even hypertrophy? How do you evaluate it? How do you evaluate it is less of a challenge as opposed to how you treat it. Since the question is evaluated is what I will stick with, you want to look and see whether there is an anterior leaflet or either of the two leaflets of the mitral valve touching the septum or not. If you see it, and you can see it by M mode, by 2D, by color Doppler, then it is present. Why is it present in these cases? It's primarily because of a mitral valve apparatus changes. Sometimes it's not just an anteriorly displaced papillary muscle, it's an anomalous papillary muscle as well, along with the elongated leaflets of the mitral valve relative to the ventricular size. Can you comment on the frequency of doing a TTE in patients with hypertrophic cardiomyopathy who do not have symptoms or outflow tract obstruction? How this change depending on age, more than 65 versus younger? If somebody is entirely asymptomatic, the clinical exam does not raise any possibility of dynamic obstruction, then perhaps every 2 years is not unreasonable. However, if there is a question about whether their symptomatic status has changed, their physical exam has changed, I would have a low threshold to obtain the echocardiogram at that time. When I think of age, I think of a functional age as opposed to an absolute age. In our practice, we've seen patients referred in their 70s who are very functional to the extent that when you look at their exercise performance, it may be better than other younger patients. So if somebody is older and I am following them up either with mild symptoms or questionable symptoms, I have a low threshold for obtaining the echocardiogram. Where is the best to measure septum and parasternal lung axis to distinguish between elderly sigmoid septum versus true hypertrophic cardiomyopathy to avoid overmeasurement? So it's not just where you measure it, but it's also how you measure it. Sometimes it's the very basal 1 centimeter or so that has the increased thickness, and as you move apical to that point, the septal thickness is not increased. Here it is important if you're looking at that echocardiogram and if you're reporting it to say, this is the place where the septum measures that much. To avoid the over measurement, if I'm the one scanning, and the advice I give to the sonographers is avoid the off-axis cuts or the oblique cuts, because these may result in higher thickness than what the true thickness is. Also combine that with the short axis views so you identify which segment you are measuring in the paralung and what it looks like in the short axis. Is it necessary for HCM patients to have 3 different imaging modalities for risk stratification? For risk stratification, you do not need all 3 different imaging modalities. I would say the echocardiogram is the starting point for sure. And in most patients, SCMR is of value as well, particularly if you're looking at suboptimal echocardiographic images, if you're looking at borderline cases in making the call of hypertrophy or not, if you're suspicious of an apical aneurysm, if somebody has some borderline risk factors and you want to sort of tip the balance one way or the other and you're looking for late gadolinium enhancement. Do you find a pre-op TEE needed? Helpful for pre-surgical myectomy planning in a low volume site? How a recent case with myectomy with residual significant SAM, dynamic obstruction, lung anterior mitral valve leaflet. So if the imaging before the TEE, in this case transthoracic and CMR, has clearly demarcated what is the problem that is present, and by that I mean the extent of septal hypertrophy, leaflet pathology, then the need for the transesophageal echo becomes less. But if that pathology is still in question, then yes, the transesophageal echo should be carefully looked at with the idea of knowing what is the septal thickness and what are the extent of the mitral valve abnormalities that are present. In some cases, the approach is not just a myectomy, but plication of the anterior leaflet of the mitral valve is essential, and the surgeon should know that because that will alter their approach. In your clinical experience, which therapy do you prefer, alcohol septal or myectomy? Because I had a bad experience with alcohol septal ablation. So a lot depends on what the findings are. Are the patients good surgical candidates or not? That's one piece. Another piece, what are the patient preferences? A third piece also that one needs to consider is the experience of the team that you have, be it for surgery or alcohol septal ablation. And the experience with alcohol septal ablation should not be minimized because there are many decisions the interventional cardiologist has to make. For example, are they able to get into the target septal artery? It's not just occluding any septal perforator. It has to be the one that leads to the part that supplies the segment of the septum that causes the dynamic obstruction. The second question for them, if they are not able, do they sort of stop and recognize their limitation, or they'll just do it anyway? Certainly not recommended. There are small target vessels that can be more challenging because of their size, because of angulation to get into, and if this interventional cardiologist has not done enough, he or she may not be that comfortable. So the short answer is, if you have a good surgical candidate, low surgical risk, solid surgeon, then refer them to surgery. If you have a patient who understands both and does not want surgery, but you have a good team that can do alcohol septal ablation well, you can refer them to these. Nowadays, I will say, I also discuss with them medical therapy before septal reduction therapy, because if medical therapy fails, you have something to fall on. We don't have to go to the more invasive route and then discover the patient didn't respond well. Now I go back to medications. So that's something that I discuss with my patients now. What would be the standard repair for SAM without asymmetric septal hypertrophy? So these are operations that are directed at reducing the mobility of the anterior leaflet of the mitral valve. And I'm not a surgeon, so I'm not going to get into more details than that. Wouldn't biplane overestimate the ejection fraction as well? Biplane would overestimate the ejection fraction if there is foreshortening. That's why one should aim to avoid foreshortening. That's why one should have a low threshold for giving contrast. The ultrasound enhancing agents frequently result, if you do ventricular volumes with them, larger ventricles than if you do not use them. So that's as far as the issue of overestimating ejection fraction. In our lab, we have a QA piece where we look at patients who have undergone both echo and CMR within 1 to 3 months, and we compare these studies as far as ventricular volumes and ejection fractions. And that has been a very valuable tool. I will submit to you, most physicians actually do not measure by plane ejection fractions. They go by dimensions. And if you were to measure volumes, you will discover that the ventricles are larger than what you think. And that could be helpful in recognizing patients with significant degree of mitral regurg. I tried to answer as many questions as I could. There was one question, how often to image patients on mavacamten? There is a package insert for the first 3 months. We do it on a monthly basis every 3 months thereafter. If during follow-up you change the dose, then you revert back to the monthly intervals. Certainly, if you have a patient who's not doing well, for whatever reason, you don't have to wait for a month before you scan them. You look at them sooner. I would emphasize here, you need to be careful with the image acquisition, and you need to be careful with the measurements of ejection fraction, and do not just go visual estimation, because there can be changes that the eye doesn't catch. Not sure if there are other questions. Can you comment on the role of mavacamten post-myectomy if residual gradient LVOT obstruction is still present? If the ejection fraction is preserved or the ventricle is hyperdynamic and there is still dynamic obstruction with a large gradient, the drug may be used. I would tell you, though, there is limited experience with its use in that setting. Okay. And I thank you all for joining us today. I hope I answered all of the questions.